I'd like to talk on something which is very important in care of patients with heart attack in India. Acute heart attack, or what we call in medical terms STEMI, is one of the devastating complications which has very, very high mortality and morbidity if you don't treat it in time and treat it well. To treat a heart attack, you not only need hospitals, but you need what we call as systems of care. Now, to give an example, if a person in US gets a heart attack, he calls a number, which is 911, which activates a whole system, including an ambulance, a pickup of the patient with acute heart attack, a diagnosis, and then shift to an appropriate center. We in Tamil Nadu have started a small pilot program which with the government of Tamil Nadu and the 108 ambulances has initiated an acute heart attack treatment for patients in 4 hub and spoke models covering about 100 hospitals in 4 districts of Tamil Nadu, which is now finished 1 year of collection of information. What this entails is a person, when he gets heart attack, he calls a number. The number is usually the public number, which is the ambulance number, which is 108, gets picked up by the ambulance, and once he goes to a hospital, the diagnosis of heart attack is made by a simple test which is called as the ECG. Many small hospitals in rural India do not have appropriate ECG machines and do not have doctors who can look at those ECGs and make the diagnosis. So we put in a system where we use a very high-end technology of telemedicine, which basically picks the ECG up and transmits it from the ECG machine into either another similar machine or onto an Android phone, which makes us the diagnosis of ECG proper and correct. Once the diagnosis of ECG is made with a device which has been completely manufactured in India, the patient's diagnosis is made and systems of treatment are started based on a protocol which is now initiated in all the small hospitals and the group of hospitals which are involved in this hub and spoke. So the basic treatment like giving of aspirin, cholesterol lowering medicines are initiated, heparin is given, and if the facility has a small ICU, then the clot busting drug, which is called as the thrombolytic, is initiated. Following the successful thrombolysis, the patient is now then shifted by the same 108 ambulance from that small hospital to a larger hub hospital, which is in the center, which is more urban centric, or in a small or to moderate sized town, which has the facility now to do a test called as the angiogram, which then decides the risk of the patient and then follows it up with the treatment, which is either angioplasty, medical treatment, or coronary artery bypass surgery. So in short, this whole treatment is initiated in an organized systems of care treatment where patients do not get confused about what to do, where to go. Physicians are clear about initiation of treatment, and within a 24-hour period gets a complete treatment which matches what is available all over the world. This sort of strategy, which the Tamil Nadu STEMI project, which myself and Dr. Thomas Alexander from Coimbatore have started in Tamil Nadu, has now completed about 2,500 patients in 1 year, and we are now putting it up for a major publication. This has also become a standard of care for acute heart attack in the country, and the framework has been accepted by both the bodies of the Cardiology Society and the Physicians of India, and is coming up with a framework paper in the National Heart Journal, the Indian Heart Journal. It's also now purported as the best care for developing and low-cost middle-income countries. As you know, in the larger developed nations and in the European nations, primary angioplasty, which is acute angioplasty in an acute heart attack, is the best care. Unfortunately, it is system intensive, it is resource intensive, and very, very expensive, and is not applicable to countries like India or China or Indonesia, which have limited resources and has widespread patients. So clearly, I think what we have tried to attempt to do is to create a new system of care in India, which could be replicated in most states outside Tamil Nadu. I'm happy to say that Telangana is the next state which is possibly going to start the program and would slowly be scaled up as a national model. Now, it has been a privilege for us in STEMI India, me, Thomas, and our colleagues, to work with the Tamil Nadu government to foster a very large public-private partnership, which has been allocated as a very, very successful program in Tamil Nadu. And we hope to replicate it in other states and in the country as a national systems program. I would also like to say that this cannot be without the involvement of the governments. The state governments have has health as their priority, and I think once the citizens of this country make health their priority and the political system establishes health as a priority, I think the governments will invest a large amount of money into systems of care, both for emergencies like acute heart attack, stroke. They've already got it in some areas like road traffic accidents, poisoning, and I think once it's scaled up, it would provide a very important public health system care which could reduce acute events in most patients.